Multiple sclerosis. Multiple sclerosis (MS) is a chronic, frequently progressive neurologic disease of the CNS of unknown etiology and uncertain trajectory. MS is characterized by the occurrence of small patches of demyelination of the white matters of the optic nerve, brain, and spinal cord. MS is the most common CNS disease among young adults and the third leading cause of disability. Pathophysiology and etiology. Demyelination refers to the destruction of the myelin and the fatty and protein material that covers certain nerve fibers in the brain and spinal cord. Demyelination results in disordered transmission of nerve impulses. Inflammatory changes lead to scarring of the affected nerve fibers. Cause unknown but possibly related to autoimmune dysfunction, genetic susceptibility, or an infectious process. More prevalent in the northern latitudes and among Caucasians. Clinical manifestations. Lesions can occur anywhere within the white matter of CNS. Symptoms reflect the location of the area of demyelination. Fatigue and weakness. Abnormal reflexes absent or exaggerated. Visual disturbances impaired and double vision, nystagmus. Motor dysfunction, weakness, tremor in coordination. Sensory disturbances, paresthesias, impaired deep sensation, impaired vibratory and position sense. Impaired speech, slurring, scanning, dysarthria. Urinary dysfunction, hesitancy, frequency, urgency, retention, incontinence, upper urinary tract infection. Urinary dysfunction affects about 90% of patients with MS and may exacerbate relapse of MS. Neurobehavioral syndromes, depression, cognitive impairment, emotional lability. Diagnostic evaluation. Establishing a definite diagnosis is often difficult, with which uncertainty concerning prognosis once the diagnosis is made. Serial brain MRI studies have proven to be useful for diagnosing and monitoring patients with MS, show small plaques scattered throughout the white matter of CNS. A new technique, magnetic resonance spectroscopy, is now being used in vivo to monitor specific pathophysiology of evolving MS plaques. Electrophoresis study of CSF shows abnormal IgG antibody. Visual, auditory, and somatosensory evoked potential slowed conduction is evidence of demyelination. Management. MS, multiple sclerosis treatment is dynamic and rapidly evolving, covering two main areas: direct treatment of MS and treatment of the affects the symptoms resulting from MS. Treatment is aimed at relieving symptoms and helping the patient function. However, the therapeutic relationship between the patient and the nurse creates a critical and strong bond that is essential across the long trajectory of the illness. Observe for motor strength, coordination, and gait. Perform cranial nerve assessment. Evaluate elimination function. Explore coping, effect of activity and sexual function, emotional adjustment. Assess patient family coping, support systems, available resources. These are all nursing assessments. Acute attacks. Corticosteroids and adrenocorticotropic hormone are used to decrease inflammation, shorten duration of relapse and exacerbation. Immunosuppressive agents may stabilize the course. Beta interferon is being used for treatment of rapidly progressing symptoms in some persons. Copolymer 1, a mixture of synthetic polypeptides composed of 4 amino acids, has been effective in reducing relapse rates and disability in patients with relapsing remitting MS. Glatiramer oxidate, Copaxone, an immunomodulator, is used in relapsing remitting disease. Once again, corticosteroids, immunosuppressive agents, beta interferon, copolymer 1 and glatiramer. Glatiramar, Glatiramar, glatiramar acetate. Chronic symptom management, treatment of spasticity with agents such as baclofen, diazepam, physical therapy, nerve blocks and surgical intervention. Control of fatigue and amantadine. Third one, treatment of depression with antidepressant drugs and counseling. Fourth, bladder management with anticholinergics, intermittent catheterization for drainage, prophylactic antibiotic. Fifth one, bowel management with stool softeners, bulk laxative suppositories. Sixth one, multidisciplinary rehabilitation management with physical therapy, occupational therapy and so forth. Seventh, controlled dystonia and carbamazepine. Controlled dystonia with carbamazepine. Eighth one, management of pain syndromes with carbamazepine, phenytoin, amitriptyline. Complications, respiratory dysfunction, infections, bladder, respiratory and sepsis. Complications from immobility and speech, voice and language disorders such as dysarthria. The nursing interventions based on promoting motor function by performing muscle strengthening and strengthening exercise daily. Apply ice packs before stretching to reduce spasticity. Second one, minimizing fatigue. Plan ahead and prioritize activities. Take brief rest periods throughout the day. Avoid overheating, exertion and infection. And energy conservation techniques such as sitting to perform activity, limiting trips, pulling or pushing rather than lifting. Then third one is optimizing sensory function, encourage ophthalmologic consultation, provide safe environment for patient with any sensory alteration. Make sure floor is free of obstacles, loose rugs or slippery areas. Fourth one, maintaining urinary elimination, ensure adequate fluid intake to help prevent infection and stone formation. Teach patient to report signs of urinary tract infection immediately. Encourage fluids every 2 hours. Follow regular schedule for avoiding every 1 to 2 hours. Lengthening hours tolerated. Restrict fluid volume and safety salty foods 1 to 2 hours before bedtime. Fifth, normalizing family process. Encourage verbalization of feelings of each family member. Suggest dividing up household duties, childcare responsibilities to prevent strain on one person. Sixth one, promoting sexual function. Encourage open communication between partners. Discuss birth control options. Teach patient and family how to conduct periodic self-assessment and daily functioning. Okay.